Okay, here's our presentation. Okay. All right, so I'm going to talk, Dr. Saxena and I are both going to talk about slightly different aspects of treatment of hip problems. Mine is more of the non-arthritic hip, and we're going to talk about some tendon injuries as well. So I'll take you through a little bit of anatomy and then some of the things that I take care of, and then Dr. Saxena will take over and talk about some of the arthritic treatments that are options for for your hip. Okay, so my talk is hip preservation, diagnosis, and treatment. Okay, I have no relevant disclosures for this particular talk. Okay, so first one, again, we're going to talk about basic anatomy. We'll talk about pathology and imaging, both very important things, especially the imaging in the hip. And we're going to talk about treatment, a little bit about outcomes, and then where we're going in the future with how we preserve your hip. Okay, so the hip is a classic constrained ball and socket joint. The ligaments are very, very strong, and it takes a real tremendous force to dislocate or injure a hip. The muscle groups around the hip are also extremely strong, and essentially your entire body weight goes right through your hip joint. So you do need to have large, strong muscles to support that joint. The hip is broken down into an intra-articular or central compartment, which is right here. Between the ball and the socket, the ball is called the femoral head. The socket is called the acetabulum or vinegar cup. There's a labrum, which is a gasket around the socket of the hip, around the acetabulum. And there's also iliopsoas, which is a tendon that comes down and flexes the hip and is a very strong hip flexor. In a peripheral compartment, which is more the outside part of your hip, that bump you can feel on the outside of your hip, that is the femur, where the femur goes into the ball and becomes the neck of the femur. And then we have the last part, it's called the peritrochanteric space, which is the bursa sac, which is on the outside of your hip joint, and the gluteal muscles, which are very strong muscles that lift up the hip and abduct the hip away from the body. So all of these components are extremely important in keeping the stability of your hip and the function of your hip going ahead. Okay, so what do we want to know about somebody who comes in my office with hip pain? I want to know if they were injured or they were not injured. Is this traumatic or atraumatic? How long has it been going on for? Again, was there an injury? What kind of things cause their symptoms? Is it sitting? Is it standing? Is it running? Is it jumping? And what kind of treatment have they had? Have they had physical therapy? Have they had medication? Have they had an injection in the hip or in the hip joint or around the hip joint? Then I want to watch people walk. Walking tells you a lot about the hip. It tells how quickly people get off that hip if it's very painful. It shows you if they have any kind of limp. You also want to look at the hip itself. Do they have any kind of hernia? That would be something a general surgeon would take care of. Do they have a contracture of the hip where it doesn't straighten all the way out? What is their range of motion? Is it equal compared to their hip that is not painful? And then we want to push around the hip and see if there's any pain as well as around the hip. We also want to look and see if there's things that we can rule in or rule out. Is it from their low back? Is it, again, from a hernia? Is it something that's not related to the hip joint but is causing them hip pain? Is it referred pain? Okay, so what I do first is called the flexion, abduction, external rotation, and the flexion, adduction, internal rotation activities, this is the FADIR, F-A-D-I-R test. And basically what we're trying to do is we're trying to flex up and pinch the socket of the hip with the ball of the hip. We want to have people do a resisted crunch. That will tell us if there's any kind of pathology coming from the abdomen. We want to look for other things. We want to look for the lumbosacral or low back spine. We want to look for the sacroiliac joint. We want to see if there's anything going on with the sciatic nerve in the back of the hip. First things first, we always want to do x-rays of the hip. Obviously, if we think it may be the back, we want to get x-rays of the low back. But we want to get regular x-rays of the hip joint before we get to any further advanced studies. Now, say we have an x-ray that looks like this, where we have a pretty well-preserved hip joint. You can see the clear space between the ball and the socket of the joint. But we have this very large hump here. You can see here is a little notch on the femur. It should come all the way around. Your mind's eye says, well, it should come down like this. Well, you see this extra bone here, and we're going to talk about what that is, and that's something we want to look for on an x-ray. Now, an MRI will tell us about soft tissues. You can see this MRI down here in the lower left shows the bump on the femur, as well as this is the labrum, and there's a tear in the labrum. You can see the fluid getting between the labrum and the socket here. So that's a tear where that arrow is. And then CAT scans or CT scans will show us the bony anatomy a little better, we can also do reconstruction so we can see the bone in 3 dimensions, which is oftentimes helpful for surgical planning. All right, so let's talk a little bit about hip arthroscopy. It really started back in the 1980s. So arthroscopy essentially is where we make small little holes into a joint. We put a camera and then we move instruments in and out of the joint without making a big open incision. It had back in the 80s had limited indications. It was really limited by technology. There just wasn't enough. The instruments were not technically advanced enough to be able to do a lot of things in the hip joint. Then around the early 90s, this diagnosis of femoroacetabular impingement. So that basically will break that down into word segments. Femoral is the femur or the thigh bone. Acetabular is the socket, and impingement means pinching. So basically we had the femur and the socket pinching on each other. FAI was the name of the diagnosis. It was first described in Europe by Dr. Ganz, G-A-N-Z, in the early 1990s. And actually back then it was treated with an open hip surgery because the arthroscopy was just not advanced enough. But people were, once this treatment became an open option, the arthroscopists were saying, well, can't we make this a less invasive arthroscopic option? And that's where hip arthroscopy really kind of took off back in the mid-2000s. So FAI, or femoral acetabular impingement, is multifactorial. It can be from some anatomic variants. It can also relate to activities that require a lot of flexion and rotation activity of the hip. Sports such as hockey, soccer, and things like that cause a lot of flexion rotation of the hip. It can be also post-traumatic. And the big question was, is FAI a precursor to arthritis? And I think for the most part, that's been proven yes. So what we have here is a normal hip, and you can see the ball and the socket. They're pretty much mirror images on the upper part and the lower part of the neck of the femur. This is the little triangle of the labrum. Now a cam lesion is what that bump was we saw in the x-ray earlier. And that's an extra area bone or a bone spur that grows on the top of the femur. And what happens is when people flex and rotate their hip, this cam lesion bangs right into the front and top of the socket and causes damage to the labrum. And over time, that can cause the labrum to tear and fail and causes pain. We also can get a pincer lesion, which is where you get bone growth on the socket side, which causes overgrowth of the socket. And then again, pinching the labrum, getting caught as an innocent bystander between the neck of the ball and the socket of the pincer lesion of the socket. And then we can have a mixed lesion where we have a little bit of pincer and a little bit of cam lesion. You get the labrum again getting caught in the crossfire. So over time, that labrum tears, and that's what causes the pain of FAI. So FAI is about 70% of my practice in the hip. So we call the cam lesion, again, it's a convexity of the femoral head-neck junction. And again, the pincer is over coverage of the acetabulum of the socket reaching over the top of the ball. And then usually it's some combination. We get cam is probably the most common pathology, and then cam pincer combination, mixed lesion would be the second most common. And again, the labrum gets caught in the crossfire between these two bony areas and gets torn, and that's what causes the pain in the hip for people. The bony lesions themselves do not cause pain, but the labrum tear does cause pain. So sometimes it's hard to tell where the pain is coming from. Not everybody presents like a classic presentation of anterior or groin pain, sometimes radiating around the back. So sometimes we'll do injections in the hip to see where the pain is coming from. We do that with local anesthetic and also sometimes with steroid. So the injection is both diagnostic and therapeutic. And surgical treatment would involve a femoroplasty, which basically means we're smoothing out that cam lesion so it doesn't pinch anymore. And oftentimes this goes along with a labrum repair, and also what we call an acetabuloplasty, which is where we smooth out the pincer lesion on the socket side of the FAI lesions. So how do we address this? Is called, generally speaking, hip preservation surgery. So we address the pathologies indicated. Typically in the central compartment, we're going to address the labrum tear. Usually it's a repair. Sometimes it's just a cleanup, and sometimes it's a reconstruction where the labrum is so damaged that we can't actually repair it, but we have to take a donor graft and make a new labrum. Then we'll also clean out the pincer lesion off the socket side. And then the peripheral compartment, we'll do a femoroplasty, which I'm showing over here, where basically you're smoothing out that cam lesion with a burr, and we're taking it from a convexity to a concavity. And then we're also going to close the capsule because we have to open up the ligaments to get into the hip joint. And then we close those back over after we're done to try to restore the anatomy from where it was in the first place. So I'm going to give you an example of a pretty classic FAI or femoral acetabular impingement patient. This is a 22-year-old aspiring Broadway dancer. She's had right hip pain for greater than 1 year. She had seen a chiropractor for this because she thought it might be from her back, and she had no improvement. Her examination was a positive flexion, adduction, internal rotation sign was positive, pain in the groin. She also had limited internal rotation. Oftentimes the cam lesions can cause a limited internal rotation. She also had what's called a C sign, which is where she puts her hand in this position and says it hurts both in the front and a little bit in the back, and she's kind of toggling between the front and the back of the hip joint. So if you look at her x-rays here, here's an AP front view of the hip, looks completely normal. Now the side view, if you look right here on the side view, there's this little, so if you look right here, here's the notch on her inside part of her femur. We come around here, there's this little bump right here, and that's the cam lesion, and that's from doing a lot of flexion rotation activities that you expect from a dancer. And that pinching over time has caused a cam lesion. And then you'll see on her MRI, which is coming up next, a labrum tear. And you can see right here, here's the ball and the socket. This is an arthrogram. So this is actually contrast dye that's been injected in the hip joint. And you can see right here, there's contrast dye undercutting the labrum here and also up in here. So that's a labrum tear. So she has a cam lesion and a labrum tear. This is what her labrum tear looks like. Okay, this is an arthroscopy. So this is looking in the hip joint with our camera. So this is her labrum, and you'll see here's the labrum right here looking nice. That's her femur, that's her labrum. And you'll see here's the labrum tear. And all that tissue that's kind of looks like crab meat hanging underneath the labrum is the tear. You see I'm lifting it up, it's not supposed to be down. So the cam lesion basically pushes the labrum into the hip joint and causes it to deform, and that causes the pain. So what we do is we go and rough up the bone and the labrum, and we put little anchors in the bone that basically repair the labrum back to the socket. So again, here's our burr, and here's our labrum repair right here. You can see we pulled the labrum back up. We've got that nice suction seal effect on the socket, between the ball and the socket. And now this is the cam lesion right here, which we're going to take out so that that labrum doesn't get pinched on by the cam lesion anymore. So that'll be the next step. That's the next video we're going to show here. Here's the next video. This is the cam after the cam lesion has been excised, and we've taken it from a convexity to a concavity and smooth. All right, I'm sorry. So again, there's the labrum repair. There's the cam lesion after we've smoothed it out. So you see now as I flex the hip up, that cam lesion is now going to make its way underneath the labrum so it doesn't pinch anymore. So that's basically a treatment for femoral acetabular impingement with a cam lesion and a labrum repair. So what do we do for patients after surgery? We put them on crutches, non-weight bearing for 4 to 6 weeks. We'll usually start therapy about 2 to 4 weeks post-op, and not really aggressive therapy. We want to protect that labrum repair. That's the weak spot of this surgery. We want to work on gentle range of motion. We want to try to control on core strengthening. We will try to get the swelling down around the hip. Everybody goes on aspirin for 3 weeks for blood clot prevention. It does happen. It is low risk, but not zero. It's usually about an 1.5 to 3 hour surgery, depending on how much of a labrum repair we have to do, how much of a cam excision we have to do. Typically about 2 to 2.5 hours. Okay, so are there complications with this surgery? Like any surgery, yes, there are risks of complication. You can get what's called a neuropraxia, which is where a nerve, because we have to put a lot of traction on the hip joint, approximately about 70 pounds of traction to pull on this to get the hip joint separated so that I can get in there and work. So the nerves that work around the groin area, the perineal nerve, the femoral nerve can get traction injuries. Almost 100% of the time, that traction injury will resolve within a couple weeks after the surgery. There can be vascular injury. There can be surface damage to the articular surfaces of the joint. Vascular injuries are very uncommon. The first thing I do is draw a line, longitudinal line down the hip. It's kind of a line of no return. I don't cross that line because all the bad structures, the nerves and blood vessels are on the other side of that line. There can be technical complications such as under-resection of the bony pathology. We don't get the labrum back exactly where we want it, or something gets missed, and then we have to get that capsule repaired back because sometimes people will have ligament issues where the capsule doesn't heal back, and that can cause a feeling of instability of the hip joint. How do we, so there was a study a couple of years ago where they looked at, should we repair these labrums or should we make a new labrum every time we do the surgery? So there was one doctor out of Colorado who suggested that we don't repair the labrum, that we actually reconstruct the labrum with a cadaver graft every time. So he found that 31% of his labrum repairs failed and none of his reconstructions failed. However, the labrum reconstruction is a much more technically demanding procedure, and it was kind of panned on an editorial standpoint that that really is not the way to go. But it should be if a labor repair fails, the next step should be a reconstruction. Should be a stepwise approach, not an either-or approach. Okay, so let's talk about peritrochanteric pathology. This is 30% of my practice. This is the trochanteric bursa, which sits on the outside of the hip. So that bump, the bone you feel on the outside of your hip joint, that's the trochanter. That's a very important structure because it basically acts all the muscles that stabilize the hip joint attached to that trochanter. Gluteal tears are the gluteus medius and minimus tendons. They are kind of like the rotator cuff of the shoulder, but of the hip joint. And then we have the iliotibial band, which acts as a structure outside the hip joint. You can get snapping hip syndrome, which is extremely uncommon. We do see in our practice over the outside part of the hip joint. So again, these do not always need surgery. Neither does FAI for that matter. FAI can be treated with non-operative means such as injections, medication, and physical therapy, same as gluteal tendon problems or trochanteric pain syndrome, as this general area is termed. You can treat it with anti-inflammatories, physical therapy, an injection, actin modification. Now, surgery can either involve an arthroscopic or endoscopic procedure or an open procedure to try to address the pathology. I do both of these things. So the peritrochanteric compartment ranges in the area of the trochanter, so it's around the trochanter. If somebody has pain, we can do surgery for this. So this is a case example of a 62-year-old female with chronic lateral hip pain. She had 5 cortisone injections and physical therapy and activity modifications, but not work. Now, if you look here on her MRI, this is the ball in the socket joint that is not involved. But here is her trochanter, and there's this white gap right here. In this area, you can see here and here, that's a tendon tear of the gluteus medius and minimus tendons that have torn off the trochanter from wear and tear. There was no trauma here, but you can get a traumatic tear of these tendons as well. So this is what the tears look like. This is the gluteus, this is the trochanter, this is the gluteus medius and minimus tendons right here. You can see as I'm grabbing it, there's a hole right there. That hole should not be there. That tendon has been torn off the bone. So what we do is we rough up the bone and the tendon and repair this similar to the labrum, but we use a combination of anchors to try to repair this back to its normal anatomic we call footprint. So this is what the footprint looks like here. There's the trochanter. Now you don't see the trochanter anymore because now the tendon is repaired back to the bone. You'll see when I rotate back and forth, everything moves as one unit here, back and forth, and that's what we want to have. And we have to get that tendon to heal back to the bone. So that does take time. So what we do with these patients are protective weight bearing with crutches or a walker for 6 weeks. It's actually, we have to be really careful with these patients. We start limited therapy at 6 weeks post-op, and again, range of motion, edema control, and core strengthening. Everybody goes on aspirin for blood clot prevention. This is a little shorter procedure, about a 1 to 2 hour surgery time. Again, this can also be done open with an open surgery, and sometimes we'll actually reconstruct these tendons with either a skin graft to try to reinforce it, or we'll actually take part of the gluteus maximus tendon and reconstruct these tendons if they're irreparable. So how are the outcomes with this? It's really a limited data set for most of these studies. And again, a lot of these studies have both people who have both the FAI treatment and gluteal tendon treatment. So here's one study where they found that the outcomes were pretty good, but again, they had both. There was not really isolated gluteal tendon repairs. And then here's a group of patients, again, had both intra-articular FAI treatment and extra-articular treatments. And again, about 90% good to excellent results with 5 years. So we're actually running a study at Rothman Institute. It's called the Gluteal Repair Outcomes Study, and began it 3 years ago. So we're doing primary repair with single row or a double row technique of anchors. And we're just doing arthroscopic primary repairs. To date, we have about 31 patients in the study. We're shooting for about 40 or 50 with 2-year follow-up. So this is a long outcome study. We're trying to figure out what the best practices for these gluteal tears. Is it repair, arthroscopic repair? Is it open repair with skin graft augmentation? Is it a gluteus maximus transfer? And we're trying to see patients who have chronic tears versus acute tears. And then a lot of patients will have these tears associated with hip arthroplasty, which Dr. Saxena is going to talk about, not the approach he uses, but a slightly different approach that is actually a very common technique for hip replacement that can involve the gluteal tendons being torn. So surgical outcomes. This hip arthroscopy is the fastest growing segment in our arthroscopy journals and literature. It's just behind them. It's number 2 behind shoulder in total volume. There is a bit of a learning curve for hip arthroscopy. Some people estimate up to 500 cases. I think it's probably around 50 to 100. Overall, the results are good to excellent about 90% of the time in the general population. There are significant complications, but they are low, but not insignificant. And technical error or incorrect diagnosis seems to be the biggest cause of failure. And that's something people in the hip arthroscopy world are really trying to work on to improve. And we need to get longer term studies because, again, these have only been really done for about the last 15 years. So we really need to work on trying to get more long-term data for this subset of patients. I want to talk about one other source of hip pathology besides we talked about lumbar spine and sacroiliac joint is the core muscle injury. The core muscles are basically where the abdominal muscles attach into the pelvis. They are very commonly seen with FAI because of loss of range of motion of the hip, and that force gets translated into the abdomen and the groin muscles, and that can cause injuries to the core muscles. And again, when you see that kind of injury, don't forget about the hip joint. So to conclude, non-arthritic hip pathology is being more and more frequently recognized in the general athletic population. Surgical intervention has become more prevalent in the last really 10 to 12 years, not more than that. Hip arthroscopy has come a long way from niche procedure to a mainstream sports medicine treatment. We need to better recognize pathology. It saw us, but we didn't see it. We don't want to miss things that we should have treated at the time of surgery, or the time of non-surgical treatment for that matter. We're trying to improve imaging and improve our imagers. We're really trying to get the radiologists on board with this, looking at MRIs with and without arthrogram contrast and ultrasound. And we're trying to get more experienced hip MRI radiologists to really help us make better diagnoses in these hip patients. Well, thank you very much. These are my kids. And if you have any questions, you can reach me through our website, arthrothmanortho.com, and you can read more about our practice and about me specifically. Thank you very much.
Josh, that was great. I love seeing the videos and just fantastic talk. I always learn when I hear from you. I think the plan was to kind of move right into kind of hip replacement here. My name's Arjun Saxena, everybody. Thanks for being here. And so let me see if I can share this screen and get us going. All right, so. All right, we good? Josh, can you see me here? Or my screen? Perfect. So, all right, hip, hip, hooray. So, Dr. Hornstein is one of our sports trained colleagues. And so he tends to deal with sort of younger or more soft tissue injuries where I am the joint replacement colleague. So I tend to deal maybe with an older population and more bone or joint destructive type issues. So the natural history here is for Josh to talk about the soft tissue injuries and the soft tissue ailments about the hip and the treatment options, and for me to talk about the bone or joint issues. So again, a little bit about me. I'm from the area. I'm from Bucks County. I went to Penn State for college. Went to Jefferson for medical school in Philadelphia, and I did a residency there as well at the Rothman Institute. And I did a year in extra training in or what's known as a fellowship in hip and knee replacement. And so hip arthritis is an extremely common condition. We're going to talk a little anatomy. We're going to talk a little treatment and some new things that we're doing in Capitol Health as well. So let's get to it. So the anatomy of the hip, I think you saw this with Dr. Hornstein's talk, but from my perspective, we do a less advanced image. We pretty much just need an x-ray. And so what we see on the x-ray is the femur or the thigh bone, and then the top part of that, which is the femoral head. The hip joint is like a ball and socket joint. So the top part of the femur, the femoral head, is the ball, and the socket is your pelvis right here accepting that ball. And so one of the most common causes of arthritis, of pain, is osteoarthritis. And basically, people talk about arthritis all the time, but what is it? So arthritis is a condition where the cushion or the cartilage in your joint deteriorates. And that's a degenerative condition, won't get better, and usually will get worse over time. And so arthritis is the really smooth surface that allows our joints to sort of function normally and allows them to move smoothly. So in all the joints, whether it be the little finger joints you have or the big hip or knee joints, there's cartilage that's cushioning or covering the end of the bone. And when that breaks down, that's what arthritis is. There are different types of arthritis. Rheumatoid arthritis is another type where your immune system actually attacks the cells around the joint. So how do we develop arthritis? Well, it's something that we typically develop over time. You can have abnormal anatomy, like let's say if you had a hip problem as a kid, you may be predisposed to developing arthritis in your 40s or 50s. You could have abnormal biology, where if you maybe don't have great blood flow to the top part of the hip bone, that can cause the femoral head to sort of collapse or die. That's a condition known as avascular necrosis or osteonecrosis. Overuse, active people can sometimes over a course of a life, and genetics. A lot of times we'll see people with hip or knee arthritis, and we'll ask them, well, did your parents or did your grandparents have this? Or they'll tell us that, hey, my brother just had a hip replacement, so I think it's probably time I did too. So there's a lot of different ways you can develop arthritis. And so again, the diseased cartilage, the loss of that cushion, is what causes bone-on-bone contact that can cause grinding of the joint, soreness, and even swelling. So I liken arthritis to a door hinge. So this is a brand new door hinge, normal functioning joint, okay? Healthy cartilage, well lubricated, full motion, and pain-free. And then if you take a lifetime of normal function, something we take for granted, and you can walk, you can get out of the car, exercise, sleep without pain or dysfunction, and enjoy life. And then, kind of life happens, right? 40, 50, 60, 80 years go by, and now you have this for your hip joint. This is a rusty door hinge. It creaks, it cracks. This is analogous to cartilage damage, loss of the lubricating mechanism, and loss of motion. And so what do we ask our patients that come in with hip pain when we're in our joint replacement or arthritis clinics? Well, we ask if they limp. The number one thing I asked, is it difficult to perform daily tasks like putting on socks or shoes or tying shoes? One thing we want to assess is, well, we understand if you have a diagnosis, but how is it affecting you? Is it limiting your activities or your lifestyle? Balance problems are sometimes common. And then as far as where people have pain, when they have hip arthritis, it's pretty common for them to have pain in the thigh, the groin, or the buttock. Pain can also even radiate down to the knee, and it's a little unbelievable for people, but I've literally had people say, hey, I'm here for my knee, and you examine their knee, you get an x-ray of their knee, and the knee looks okay, and then you examine their hip, and you say, oh, it's probably the hip, and an x-ray shows pretty significant arthritis, even though they don't have any complaints up there around the hip. So how can we treat hip arthritis? Water therapy is great, whether it's swimming in a pool or heat or ice. Those things can help all of our arthritic joints. Exercise and physical therapy are good for weight loss, and believe it or not, motion is good for all of our joints. So there's data that shows that basically motion of a joint can actually help release, and exercise can actually help release endorphins, chemicals that actually make you feel better. A sedentary lifestyle or not moving is going to lead to more stiffness and more dysfunction. Medications, you can take anti-inflammatories or Motrin or Tylenol. These things can help with our arthritic pains. And then steroid injections, as Dr. Hornstein mentioned, you can do a steroid injection for a soft tissue injury to the hip, but you can also do it for arthritis, and that can help with pain. When those things fail, the next step is often a hip replacement. And people always ask, well, when should I have the hip replacement, doc? And the answer is when the pain and dysfunction are so severe that you can't deal with it anymore. And so hip replacement is a great surgery, helps relieve pain and mobility, and it's become more and more common. In 2009, there were about 300,000 done in the United States, and now it's even more than that. So what exactly is a hip replacement? Well, here's our picture from the beginning of the talk, right? We have the thigh bone here with the ball on top and the socket. And here's what a hip replacement looks like. You put a metal stem inside the femur bone. You put a metal shell or metal cup inside the pelvis here, the socket, and then a head and a liner can articulate to really, truly recreate that joint. And that's the goal, is recreate the joint to bring back your normal function. So here's an x-ray of a hip before surgery. You see the bones touching right here. There are cysts in the bone, and the bone is very sclerotic or white and hard. And here's an x-ray of a hip replacement. So there's a metal stem inside of the femur. There's a metal cup or shell inside of the pelvis. And then there's a ball with a liner right here to articulate and hopefully recreate that anatomy and that motion. So one thing that we do at Capitol Health pretty commonly is called an anterior approach. Most people, if they have a hip replacement, or know people that have, classically, a lot of the incisions will be on the back or the side of the leg. With the anterior approach, we can do the incision in the front of the leg, and we can work between muscles and tissues without detaching them from the hip or thigh bone. So the hope is that it might lead to a slightly faster recovery. In traditional surgery, most patients in hip replacement are laying on their side. With the anterior approach, we have people laying on their back. And the way I do it is I actually use this torture device right here. Don't worry, you're under anesthesia, you're not going to feel this. But the patient's lying on their back, and because there's all this open space here, I can actually, in surgery, bring an x-ray machine to check the components. And so that's how I like to do it. It works pretty well for me. And so the anterior approach is actually not new. It's been around for a number of years, but probably in the United States, it's relatively new and becoming increasingly common over the last 20 years. And so overall, hip replacement, no matter what approach you have, is a great surgery. Most patients, 96, 97%, will say the hip replacement was a great thing. And the most favorite thing I like to hear from patients when they come to the office, usually about 4 weeks after surgery is the first visit, I love to hear them say, I wish I'd have done this sooner, because it's really a great procedure and it can really alleviate pain and dysfunction. So in summary, on hip arthritis, the leading cause of hip pain is osteoarthritis as we age. And osteoarthritis is a degenerative condition over time, and it won't get better. It'll probably get worse. Early diagnosis, using the non-operative treatments is important, and a hip replacement is a great procedure to relieve pain and improve mobility. Now, as with anything, hip arthritis and hip replacement have evolved over the years. And so what can you expect? You know, in years past, people used to go have surgery and they'd lay in bed for a few days and go to rehab for a couple weeks. And things have changed a lot. That's probably mostly what's changed in the last decade. So for as far as the hospital stay, typically it's one night, or even people will leave the same day after surgery. We'll get to that in a minute. Additionally, you're going to walk the day of surgery. And what we do is we really improve how patients recover. And if we found that if we can control your pain and your nausea, we can get the therapist to work with you, and that can allow you to walk the day of surgery. That can prevent complications that we see when people are in bed or sedentary for long periods of time after surgery. And then the hope is that people can return to work. Usually it takes a couple months, but depending on the job, if it's a more physical, active job, it's a couple months. If it's a more sedentary or desk job, or what we've seen with the pandemic is most people or a lot of people are being able to work from home so they can get to work a little faster. So a lot of talk these days is about outpatient joint replacement. Not actually something new, been around for about 2 decades in our country. We've been doing it in Mercer County for about 5 or 6 years. And really, again, the pandemic has sort of sprung this in that it's people think, hey, I'd rather be at home than in the hospital. And it's much better to be home than in the hospital. You don't have someone waking you up at 2 in the morning to check your blood pressure. So if you're healthy and you can do it, doing hip replacement surgery as an outpatient basis is great. So basically, what is it? It's basically having a joint replacement, a hip or knee replacement, and going home the same day. And like I said, it's more common now because of COVID. And it's also helpful as far as a financial situation. If you're outpatient, there may be less cost to the patient. So it's become more common. And it's also been proven now, because it's more common, it's proven to be safe. And so that's another reason it's becoming more common. So the question is that, am I a candidate? And the big thing is you got to prepare. And so the most important thing we have when we talk about outpatient joint replacement is safety first. So number one, it's about patient education. It's about their expectations. Just because you're going home doesn't mean you won't have some discomfort or won't need help the day of surgery. So that's really important, that patients have a support system, that they can expect that, this is going to be a process. Additionally, patient selection is really important. If you have cardiac or lung issues, it's probably best to stay home, stay in the hospital one night at least to be monitored. So your lower risk patients, what's called the anesthesia safety classification, are better for this. We also want our medical conditions to be well controlled. So diabetes has to be well controlled. BMI of 40 is probably the largest we would want to do if we were sending someone home the same day. Certainly want them to be smoke free. And then anemia. Anemia or low blood counts is something that can cause complications in hip or knee replacement. So we definitely want that to be optimized. We want you to have normal hemoglobin levels before surgery. The idea with outpatient replacement is that basically the expectations as far as what you're going to go through surgically are the same. So the same infection prevention, you're going to use wipes before surgery, we're going to do nasal swabs before surgery, all things to minimize the bacteria that could potentially infect your hip or knee. Room, instrument cleaning, all these things are going to be the same. So there's no drop off in care by doing outpatient joint replacement. It's just a question of being able to go home and sleep in your own bed, really. And so one of the reasons that outpatient joint replacement is possible is over the last 10 to 15 years, we've really adopted something called multimodal analgesia in orthopedics. And what that is it's using different types of pain medicine to take care of your pain. So in the past, you may get like a morphine pump or something like that. And that's just not something we do anymore because we know there's so many side effects of those types of drugs and we don't want people to get addicted. And so what multimodal analgesia is, we'll use different types of medications all at the same time. And what that does is it'll hit the pain pathways in different places. So we'll use something like a Tylenol, an anti-nerve medication like Neurontin or gabapentin or Lyrica. We'll use anti-inflammatories, Toradol, Meloxicam, or Celebrex. We will even use some narcotics too. They have a role, we just don't want it to be the only or the main role. And so we give these medications before, during, and after surgery. And that allows the body, when we're giving them before, for the pain receptors to sort of be activated and be ready for the pain that's coming, because there is a certain amount of pain or trauma associated with surgery. Additionally, it's really important with outpatient therapy to work with a therapy team to make sure that you're safe to go home from the hospital. Sometimes preoperative physical therapy is helpful so patients can kind of understand how they're going to move. Medical equipment like walkers, canes, things like that, planning ahead to get those. And what we do at Capitol Health is we actually have our therapists come to the recovery room to see you if we've identified you as an outpatient candidate. Additionally, one thing a lot of people have in their home is stairs, and that's a source of anxiety for our hip and knee replacement patients. So we actually have steps that you can practice on, not only if you're admitted to the hospital and stay overnight, but also if you're going home the same day, we have them right in the same day surgery unit. And so that's a really exciting thing, an exciting initiative that we're really pushing for at Capitol Health. We think patients just do better when they go home. Certainly though, if there's any concerns, any issues, we want it to be safe. So if a patient needs to stay one night in the hospital, that's also reasonable. People always ask when I do these talks, how can you prevent a joint replacement? And some of it's genetics, like I said, some of it's biology, some of it's anatomy, and there's not much you can do. But the keys really to prevent developing arthritis or developing symptomatic arthritis are staying active and controlling your weight. We know that there's a direct correlation between higher weights and a higher incidence of arthritis and potentially requiring surgical or non-surgical treatment. Thank you. That was what I had for everyone tonight. I see there's some questions there, so maybe we could start those now. Josh, maybe I can read some questions and we can take them on together. So number one, in the chat box, there's an eval link. We would love it if you could fill that out for us. That will hopefully allow us to improve programs in the future. One question was, can a person be a runner after a hip replacement? My goal with hip replacement, and I think Josh will second this with all of his procedures, is we want patients to get back to the things they want to do. And so I tell people, look, you don't have a restriction. I also tell people that now you have a metal and plastic part in your body. So if you want it to last longer, you do have to take care of it. So things that, activities that have repetitive pounding, like running, may or may not be ideal. It could cause an implant to fail earlier than it would have otherwise. But again, that being said, I do want patients to get back to what they want to do. And some people just love to run. It's cathartic. It makes them feel good. And if that's the case, there's no contraindication. So you can run after a hip replacement. Sometimes though, I'll recommend people just try to modify their activities. So maybe instead of running, switch to biking, elliptical, swimming. Those things are all good cardiovascular activities as well. Someone is a fit and active 45-year-old who's been told they're too old for a good outcome with arthroscopy and too young for hip replacement. PT, activity modification has failed. They live on steroid injection, ibuprofen, and they're really struggling. And so this is a situation that Josh and I go back and forth with patients sometimes. Hip replacement, we ideally would like to do it in older patients, 50, 55, 60 and up. But sometimes, patients that are in their 40s would benefit. So Josh, let's say you would see this patient first. How would you handle it? Because certainly know that hip arthroscopy, as we get into the older population, can lead to development of arthritis faster.
Yes, absolutely. And the idea, again, my topic was hip preservation surgery. So I'm trying to preserve your hip. Now, the question is, if you have any arthritis, if there's arthritis, unfortunately, arthroscopy is kind of off the table. And that's where Dr. Saxena would come in. And sometimes it's very hard to tell, especially in I'd say our classic patient is a 45-year-old female patient who it's hard to tell if they have arthritis, even on X-ray and MRI. And really, unfortunately, there's a zero tolerance level for arthritis with arthroscopy. People really have been shown, if they have any arthritis, to do very poorly with arthroscopy. So what Dr. Saxena I try to do is really try to do our very best to make sure there's not an arthritic component to the patient's problem before I consider arthroscopy. 45 is not too old. I say my oldest patient for arthroscopy is a 67-year-old. He was a doctor. He talked me into it, and he had no arthritis. He did great. Again, more typically, I prefer to keep it below 55. This was a special situation, and he understood that there was a high risk over the age of 60. It's like a 40% risk for conversion to hip replacement for those patients. So, but I think 55 and under, I think if you have no arthritis, I think it's really a reasonable option, with the understanding that sometimes the arthritis can sneak up on us. Dr. Saxena have had a couple of cases that has happened, unfortunately, but we really try our best to avoid the arthritis. So I think as a 45-year-old if you have no arthritis, you have a cam lesion, like we said on the X-ray, like I showed, as well as a labrum tear, I think it's very reasonable to consider an arthroscopy if you've failed all other modalities of treatment. Let me read the next one here. One other thing about that, the insurance companies will give us a very hard time with these surgeries. They consider it sometimes experimental, even though it's been around for about 12 to 15 years. I'd say probably on mine, 1 out of 5 of my hip arthroscopies I have to fight the insurance company with. But really, if you document all the appropriate things as far as the cam lesion, the labrum tear, the fact that the patient has done non-operative means, such as you've done with physical therapy and medication and injections, usually that one we get approved 99% of the time. So if you've done now, sometimes we haven't dotted the I's and crossed the T's. That's when we run into trouble with the insurance company. So it is a battle, but to me, I will always go to bat for my patients if I think they're really legitimate, good surgical candidates.
Carrie, bottom line is maybe an evaluation from Dr. Hornstein would be appropriate. My mouse is going around this VIP line. Call that number and get an appointment with Dr. Hornstein and find out your options.
Thank you, Arjun. Let me read the next one here. Why can't the cartilage be replaced or built up? Arjun, do you want to take this one? Or do you want me to take this one?
You can take it. You're the cartilage specialist.
I'm the cartilage guy. So cartilage is like the holy grail of orthopedics. It is a very difficult structure to rebuild. There have been many attempts to make new cartilage. The problem is that the analogy I give my patients is that in 2021 for orthopedics, if we have a pothole in the cartilage, we can do a really good job with filling the pothole with replacement cartilage. If you have a bad road service, you have to repave the road. So basically what Dr. Saxena spoke about is that arthritis is a bad road. Certainly in the hip, there is some movement towards pothole treatment. We do a lot more of that in the knee. The hip is still kind of a new area for cartilage replacement. But unfortunately, when the whole hip is bad, you can't just take cartilage and replace it. It's very difficult to grow. It's like trying to plant grass on top of concrete. It's a very difficult tissue to get to grow and to take with results, even in the pothole situation where you're just replacing, maybe a 1 by 1 inch piece of cartilage results in the 80% range. So it's really a difficult tissue to grow. So that's why Dr. Saxena has work to do every week, because unfortunately you can't replace all the cartilage in an arthritic joint. You have to replace it with metal and plastic at this stage. Now, Arjun, can you speak to the longevity of a hip replacement? Because that's the next question. I think that goes nicely from the cartilage talk.
Sure, yeah, hip and knee replacements, we have great data that show they're lasting 20 years, about 80 to 90% of the time. And that doesn't mean they're failing your 20 in day one. It just means that, you know, it's really hard to do 20-year follow-up studies. And so depending on your age, depending on your activity level, you know, at some point when, you know, whether in your 60s or your 70s, it's reasonable to hope or expect that, you know, if you're getting a hip or knee replacement, that you'll be able to go on with this for the rest of your life without needing another procedure there. That being said, that if there's an 80 to 90% success rate over 20 years, there's also a certain failure rate as well, whether it's 0.5 or 1%. And nowadays, we're actually doing hip and knee replacement in younger and younger patients because people are kind of out of the non-joint replacement options. And so we'll see how those people do. We certainly hope that the parts and the surgeries are better than they were 20 and 30 years ago. So hopefully they'll last longer. But, you know, if you're 40 or 50 looking at a hip or knee replacement, you also have to be realistic and say, hey, there's a chance I might need another surgery at some point down the road if the plastic piece wears out, if the metal breaks, if the bone loosens from the implant, or if there's a fracture or something like that at some point as you age. Next question was any age limit to outpatient hip replacement? That's a good question. When we were establishing our protocols at Capitol Health, we did kind of make a limit of 75 years old. The reason for that is that we know that as patients age, they tend to have more complications with surgery. So we just don't want you to go home, have a complication, and then come back to the hospital. But that being said, if there's somebody who's a really healthy, 78, 80-year-old who had a really good support system at home, probably reasonable to still consider an outpatient joint replacement. Looks like Josh got the other question. How long does a hip replacement last?
Next one is,
go ahead, Josh.
Any type of doctor treats spine scoliosis and osteoarthritis of the hip and knee causing pain. Well, that would actually be two separate doctors. You would have a spine specialist, either a surgeon or a non-operative spine specialist treating scoliosis. And then Dr. Saxena would be a treater of osteoarthritis of the hip and knee causing pain. And again, not everybody, I know we talked about replacement tonight, but not everybody who comes in needs a replacement. Certainly there are other options, cortisone injections in both the hip and the knee. There's what we call viscosupplementation, which is a gel lubricant injection, which is on label for the knee, so we can't really use it for the hip, but it is an option for the knee. So not everybody, I treat people with arthritic hips and knees all the time, and they don't all end up in Dr. Saxena's office. Sometimes they will get better without surgery.
Yeah, and that's a good point, Josh. Just because you have hip or knee arthritis, it's not the end of the world. It's a treatable condition. And people live with hip arthritis and knee arthritis for years, oftentimes, before getting a surgical treatment. And when you do need the surgical treatment, it's also not the end of the world. As far as diagnoses to have, it's not a bad one because it's very treatable. And the surgery is typically very, very successful. I think at this point, there's about 1 to 1.5 million of these procedures done every year in our country. And so it's a fixable problem. Though certainly I can understand that surgery and any type of medical issue can be intimidating and cause anxiety. That might be it as far as questions.
Yes, and I wanted to say thank you for joining us this evening. I definitely learned a lot from this presentation. We'll be sharing it with my father. So thank you again for joining us this evening, Dr. Saxena and Dr. Hornstein.
Thanks so much for having us.
Our pleasure.
Looks like there's one other question I'll try to answer real quick. It is, where was it? It was what type of hip replacements are out there? Do you have a favorite one? It's actually interesting. There's a lot of different brands out there. There's probably over 100 implant brands. There's 4 big ones. And they all, if one was better than another, they'd all just copy that one, or they'd only be one. So they all work. All the major companies have multiple actually models, and they all have good outcome studies. So you pretty much tend to use something you're comfortable with, sometimes something you've trained with, but they're all pretty similar. But thanks, everybody. Those were great questions. And thanks to Capital, Marsha and her team for hosting. They do a great job. And there's a lot of other good opportunities for community education. So please keep looking at your emails, keep looking in the mail. And we love the participation of the community.